So sarcoid's been known as a mysterious disease for a long time before that. It's actually, there's a Sherlock Holmes story that's in theory about sarcoidosis too. So Sherlock Holmes was contemporaries with the first doctor who described the disease in like the late 1880s, and one of the Sherlock Holmes stories, he basically, just like House picks up on, what's challenging and interesting, and the writers for that recognize that sarcoidosis makes a good medical mystery, so Sherlock Holmes picked up on it like 130 years ago or so, good company there. So I actually have a little bit more narrow topic than what Lisa was talking about, but I do think this is relevant and it doesn't get talked about a lot. So, one of the things Lisa said is that most of the doctors who take care of sarcoidosis are pulmonologists, but she mentioned that 25% of patients have skin disease. And I don't think most dermatologists would be comfortable managing patients' lungs or heart or cardiac sarcoid. Most pulmonologists also find not so comfortable managing patients' skin. And just like Lisa said, sarcoid can look like a lot of things. I'm going to show you a whole bunch of pictures. But what sometimes happens is that patients who have skin lesions are assumed to have skin manifestations of sarcoid, but really they're due to things like side effects of therapy. If you're on steroids and you're going to get steroid-induced acne, sometimes that can be presumed to be skin sarcoid, and then you're inappropriately over-treated because of the skin manifestations. They're really more of a side effect of therapy. Just to touch on what you're talking, I got audited at Penn because I'm the only dermatologist who ordered cardiac MRIs, and I ordered so many and they thought I was doing something wrong. And I got in trouble with the institution, and it's very, very hard as a dermatologist to interpret cardiac MRIs actually. So I've cut back, but it is an important point. So I'm going to focus mostly on skin disease now, and I don't have any relevant conflicts of interest. I'm going to discuss treatment a little bit for skin disease, and again, none of these things are FDA approved. So this is a typical sarcoidosis patient, and one of the things Lisa touched on is that different organs are affected in different patient populations. So you do see more skin sarcoid in American patients, but also some patterns of skin sarcoid lesions that may link with different higher likelihood of having certain specific patterns of internal organ involvement, and maybe even responsiveness to therapy in some cases. And then you saw these pictures Lisa showed of chest x-rays and CT scans and PET scans. Skin is easier, it's right there. So when she said it's really hard to biopsy the brain, she's right. When she said it's really easy to biopsy the lung, she's a really good pulmonologist. It's way easier for me to biopsy the skin than it is for her to biopsy the lung. I'll tell you, if I do a biopsy and send it to Mary and we get lung tissue back, we went way too deep. And it does not work very intending to go for the skin. So this is a typical patient. It's a young African-American woman, and most of the lesions we see for sarcoid tend to be on the face, and they tend to be around like the openings of the face, especially on the nose. And they're often described as having this pinkish purple color. So these are like pinkish papules, in this case clustered around the eyes, nose, and mouth. You can have more severe involvements. This is a patient who has what will be described as lupus pernio. And there are a lot of confusing things in sarcoidosis. And if you have sarcoidosis, I think many doctors just blame any symptom you have on your sarcoidosis. Or if you have sarcoidosis, many doctors get scared and don't know what to do, and that's unfortunate for patients. I think some of the nomenclature is confusing even for doctors. So there's a disease called lupus that has nothing to do with sarcoidosis. There's a disease called pernio that has nothing to do with sarcoidosis. And then there's lupus pernio, which is a specific skin sign of sarcoidosis with these kind of crusted plaques or nodules around the nose and the cheeks. And this tends to be really hard to treat. And so when patients have skin sarcoid, it tends to be a little bit more chronic of a disease in general. When patients have lupus pernio, it really does tend to be very chronic and recalcitrant. And these are patients who we know may have certain patterns of internal involvement, like maybe sinus or upper airway, but also maybe are going to need to be treated a little bit different with specific agents for that. A little bit more common manifestation are these papules, which are these little fine bumps. And I'm going to show you this whole spectrum. Really, the disease can look like a lot of different things. So this is a patient who has plaques on her back. These are these big like purple lesions on the upper back and the shoulder there. I'm not going to try to use the pointer because that maybe I will. I'll be brave. But oh yeah, here. So these little purplish plaques up here on the back in this case. One of the places that we always think to look in patients with sarcoidosis, besides around the face, is asking patients if they have any scars or if they have any tattoos. The sarcoid tends to like to appear in those areas, and we don't know exactly why. Some of the inflammation involved in sarcoidosis is also involved in wound healing, and so it may be that in these places there's a little bit of an abnormal response to wound healing. This is a patient who actually has a lot of underneath the skin or subcutaneous involvement, but also these kind of flat papules around the scar here. I think it's important for pulmonologists to be good at looking at the skin, because sometimes And most places, when dermatologists aren't willing to see patients in a timely fashion, they might move to do lung biopsies when patients might have really subtle skin manifestations. So this is a mixed audience. I had to cut off the top of this tattoo. The tattoo is not for general consumption, but if you look at this tattoo, you might think there's nothing special here, but actually all of these little bumps are actually sarcoidosis. So this is a patient who had lung sarcoid, was presumed to have possible sarcoidosis, was planned to have bronchoscopy and a biopsy through the lungs, but because we have a very close relationship with the pulmonary department, they actually send these patients often to get skin exams to look for some subtle things, because sometimes we can save people more in invasive biopsy. And to Lisa's point, if you have a biopsy that shows granulomas in your skin, that doesn't mean you have sarcoid. It's not enough. You need to have the clinical symptoms, you need to have radiological findings. If you have like a splinter, you'll have a granuloma, or if you have some acne or rosacea, you can have granulomas. And that's a fair amount of the referrals I see from dermatologists are, they biopsy a spot on the face, it's a granuloma. They tell the patient they have sarcoid, and they realize it's like one spot on their skin and nothing else. That's not really going to be sarcoidosis. Often tattoo involvement is a little bit more obvious, and so this is like an obliterative tattoo. With therapy, we did fix this patient, and that was her ex-boyfriend's name there, and that was the downside of clearing lesions. This is subcutaneous sarcoids, so it's a little hard to see, but there are these nodules underneath the skin here, and some people think that might have certain prognostic implications. Sarcoidosis can look like just about anything. So if your heads are spinning, that's okay. Most doctors who see these pictures start getting stressed out by how varied sarcoid can look like in the skin. Even most dermatologists get stressed out by how varied sarcoid can look like in the skin. The main take-home point is that sarcoid really can look like a lot of different things on the skin, so doctors should have a very low threshold to think about, well, the skin is so easy to biopsy or so easy to sample. If someone is known to have sarcoid and there's a question of does their skin activity flare with their disease, or can you use the skin to monitor the disease, or certainly at the beginning of disease onset, skin can be involved right at the onset, it can be the first organ, and sometimes like in cases like this, it can be the worst organ, and there are a lot of reasons to try to partner with the dermatologist if there's any suspicion for skin involvement. This is just some more pictures of different, a little bit less common, but this is hypopigmented sarcoid, so it's where you've lost the pigment in the skin. This is verrucous sarcoidosis or hyperkeratotic sarcoidosis. This is an area of confusion in dermatologists. This is actually a patient who, she had a biopsy here of this, and it was interpreted as a squamous cell cancer, so she had surgery for squamous cell cancer and then developed all these things around the scar. If you look deeper at the biopsy, underneath this excess skin, there were granulomas. It's not common for darker skin patients like this to have squamous cells, and this is actually an area of misdiagnosis for dermatologists also, potentially. Sarcoid can affect the nails also. This patient has in the fingers, but also affecting the nails. It can affect the hair, and it can affect the mouth. So it really, you can see it almost anywhere. And then this is just just to be inclusive. All those pictures I showed you are real, they're classic sarcoid lesions where if you biopsy them, you'll see the granulomas that have been talked about. That's really the pathogenic inflammation that you get. There's this second thing that you can get in these patients who have more acute sarcoidosis. It's called Lofgren syndrome, and with that inflammation, you get these kind of reddish-brown lumps underneath the skin on the anterior shins. This is called erythema nodosum. There are a lot of other diseases that can cause erythema nodosum, so it's like a non-specific finding in some subsets of sarcoid. But if you do see this is again another skin sign that has specific prognostic implications. So when patients have this, they might have some bad symptoms right at the onset, but usually it's acute and self-limited sarcoidosis. It's just more Lofgren syndrome. And so skin biopsies can really show you the granulomas really pretty nicely. So, Lisa talked about lung biopsies, it's pretty easy, and you get the tip of a pencil-sized biopsy. We usually get the back end of the pencil-sized biopsy, so we do pencil eraser-sized biopsy, so you get a little bit more tissue, but these are all granulomas here. This is the top of the skin of the epidermis, and these are all the granulomas from sarcoid kind of through the dermis. There are some ways that you can measure sarcoid disease activity in the skin. So again, Lisa also talked about a little bit about clinical trials and how to study the disease. There are a number of different tools like the SASI, the CSAMI, use of things like ultrasound, and then outcomes instruments to see the impact of the disease. And then we have a lot of treatments for skin sarcoid, and I think we say that like I'm not making treatment recommendations for anyone in particular, but there are some non-steroid treatment options that can be used for skin sarcoid. We usually talk about kind of ramping up, so that generally we think about mild disease using something called anti-malarial agents, or something called Plaquenil is the generic, the brand name. Hydroxychloroquine is the generic name, or methotrexate, or sometimes moving on to the biologics or TNF inhibitors for more severe disease. There's a whole bunch of skin-directed therapy that if you have a dermatologist you can work with. So this is a patient who had a lot of lumps within the tattoo where that red bar is, and this is just with high-potency topical steroids. You can see some clearance of pretty robust sarcoid inflammation. This is that guy with a scar sarcoid with all this kind of lumpiness underneath the skin. That's also cutaneous sarcoid, and you can see clearance of these lesions with injections. So these are not systemic treatments. These are patients who are getting just targeted skin-directed therapy. And then there are these immunomodulatory, non-immunosuppressive drugs that we use for skin sarcoid. Some of the issues is a lot of these drugs will help skin sarcoid, but not multi-organ disease. So this is with an antibiotic called minocycline. About 2/3 to 3/4 of patients with skin sarcoid will respond. This is with combination therapy with an antibiotic and with Plaquenil. You can see some improvement in some patients. There are a couple of other agents called pentoxythioline or Trentol, or Apremilast, which is Otezla, which have been studied in small numbers for skin sarcoid patients, and also are in theory not immunosuppressive, or not as immunosuppressive as some of the traditional agents. Steroids are okay. We use a lot of methotrexate in skin sarcoid, and you can see fair responses. And again, this is you don't have to be a physician, and you don't have to do any invasive testing or imaging or radiographic testing to see when patients are getting better. Pretty sure you can see that the right side picture is improved from the left side. That's after methotrexate. And then we have some biologic options for these TNF inhibitors, which are very promising. Dr. Judson's talking next. This is one of the earlier reports of skin sarcoid with TNF inhibitors. And then this is this patient I started with. This is with traditional treatment. She got a little bit better. This is with biologics. She's been got a lot better. And we have a number of examples of patients. Actually, at this point, there's probably about 150 or so reports in the literature about patients with skin sarcoid improving with biologics. So that's my quick overview of skin sarcoid. I'm here for you. I really like taking care of sarcoid patients and their families, and I think a lot of times people bounce around without getting answers or seeing doctors multiple times until they see someone who actually seems like they know what they're talking about. I do think it's important to have a team of doctors who can take care of these complicated diseases, but I'm also open to feedback. So there's other things that you guys think that patients would want to hear about with respect to skin sarcoid. You can let me know, or you can let Kelly know, and Kelly will pass it on.